Carle combines clinical care, health insurance, and research in a way that solves problems today with an eye toward the future. Supported by a deep philanthropic spirit and dedicated to making life better for as many as possible.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HSHS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HSHS St. Anthony's Memorial Hospital.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System.
Hi, I'm Keanne Armstrong, and I'm your host for Being Well. Today we're going to be talking about colon, rectal cancer, and all of the different things that you want to know about that. And joining me today is Dr. Iyoob. You are a colon, rectal, and general surgeon with St. Anthony's Memorial Hospital. So thank you so much for joining us today.
Thank you for having me, Keanne.
Yeah, absolutely. Well, let's talk about you for just a moment. Talk to us about what type of surgeon you are. Give us a little bit of your background history.
Sure. I'll start off with thanking you for giving me this opportunity to interact with the local community.
Absolutely, thank you.
And inform them of the services available. I like both at Effingham, Charleston, and adjacent counties. And my name is Dr. Iyoob Ilyas, and I'm a colorectal and a general surgeon. And I work at St. Anthony's Hospital at Effingham. And about me, I completed my general surgery residency from University of Arizona. And then went on to do my fellowship in colorectal surgery from Henry Ford Hospital in Michigan.
All right.
And since then I've been at St. Anthony's practicing both general surgery and colorectal surgery for about a year now. And prior to that I also had the privilege of training and working at Cleveland Clinic, Florida, and at the University of Oxford in England for about 4 years. I also hold a membership from the Royal College of Surgeons in England.
Have an extensive background of training, it sounds like.
Yeah. It is, yeah.
So we're here to talk about colorectal surgery, cancer, and all the different things. So can you tell us a little bit about what is colorectal cancer? How do you explain it?
Colorectal cancers are cancer which develop in the linings of the colon and rectum, and they present in various forms and shapes. And it affects usually patients who are older. The usual presenting patients are in the range of between those who are about 50 years and above.
All right.
And colorectal cancers, when they present, a lot of them present as asymptomatic cancers. I have to mention to you about colonoscopies, the role of colonoscopies in colorectal cancer, and how they're presented, how do they come into the picture here. Over the last 25, 30 years, we've been doing more screening colonoscopies. So we are able to identify these cancers very early.
Oh, that's important.
And they are not even symptomatic as yet. So what it does is we either identify polyps, which are benign pathologies. And you've left the polyps for long enough, those polyps go on to become advanced polyps. And then there are some changes on these advanced polyps called precancerous changes.
Okay.
And if you wait long enough, those changes go on to become cancers. So those patients whose polyps are identified by colonoscopy, they are asymptomatic. And then early cancers are also asymptomatic. So essentially, patients can have colorectal cancer with no symptoms. So that is where it is important to know and follow the guidelines that after 50, we should get a colonoscopy, and every 10 years after for average risk patients. We'll talk about colonoscopy as well further down and how it's helpful.
Okay.
Those who have a little bit more advanced cancers and those who have metastatic cancer, when I say metastatic cancer, means the cancer is spread to other parts of the body. They present differently. And the location of the cancer also matters. Those cancers which are develop in the rectum present a little differently compared to those on the left side of the colon. The transverse colon is across the belly, on the right side colon. depending on the size of the mass and so on. So symptoms patients should watch out for is even abdominal discomfort or kind of abdominal pain, change in bowel habits, like some days you have diarrhea, some days you have constipation if it goes on for a few months, and loss of weight. If you see any bleeding from the rectum, and also sometimes you feel tired for a long time and we work you up and then find out to be anemic. What happens is these tumors go on bleeding for a long time that they turn patients into anemic.
All right. Now, would you notice that bleeding out of the rectum, or can that happen internally and you're not aware of it?
It can happen so slow that we wouldn't know. So we
Okay.
have to do blood test, means examination of the stool to identify if there's any blood in the stool.
Okay.
That can be done at the primary doctor's office, or check your blood and then see you're anemic. Now we'll go around finding out where is it bleeding from. And that's when we end up identifying a lot of these cancers.
All right. Yeah. So people really need to pay attention to their body and the changes that are happening. And if they notice any of these things, then they need to go to the doctor to get it checked out.
Absolutely.
Don't be shy about it.
Now, not to be shy about it at all. It's an important healthcare issue for the country. I would say this is the second most common second leading cause of cancer-related mortality. So we lose about 50,000 patients every year to both colon and rectal cancer in the United States alone.
Yeah, that's an amazing number.
Yeah.
Wow.
And it's just not that. Like, we also diagnose close to 100,000 patients with colon cancer every year.
Really?
And another 40,000 with rectal cancer every year.
My goodness.
These are huge numbers we're
They
talking
are
about.
huge numbers. So what do you attribute to these cancers developing? Do you?
Yeah, like Fred, our production manager, said earlier, if you live long enough, you develop polyps. You live long enough after the polyps, those polyps can go on and become cancers. So age is a very important issue.
All right.
Second is lifestyle changes. Our dietary habits have changed quite a bit in the last 20, 30 years. We eat a lot of processed food.
Yes.
Here, processed meat has been identified as a risk factor, and red meat is an important risk factor as well.
Okay.
Alcohol, smoking, and one of the most important healthcare issue to the United States is morbid obesity. That increases risk for a lot of cancers,
Yes.
including colorectal cancer.
Yeah. So pay attention to your diet and what you're eating, because it can affect your body.
Absolutely.
Yeah, so right here in the Midwest, there's a lot of people that eat red meat. I mean, there's people that are taking advantage of all the vegan and all the different things these days, but that's interesting. And even the processed meat, that's a quick thing for people just to grab and eat, but I guess we need to be careful of that.
I have to mention one of my mentors was one of the prominent colorectal surgeons in the country. He's a vegetarian because of that.
Oh, really?
He turned into vegetarian,
Yeah, well,
to
it
reduce
would
the
make
risk
you
of
want
colorectal
to.
cancer,
Yeah, absolutely. So I guess we're talking about some of the things that make people more susceptible. Is there anything outside of what you just mentioned with foods and smoking alcohol?
Well, some of these cancers in certain patient population, they are more predisposed to cancers, like patients with ulcerative colitis, Crohn's disease. These are diseases of the colon. These are called inflammatory bowel diseases. These patients, because there's a lot of inflammation on the wall of the colon and rectum, they are more susceptible to cancers. Also, there are some genetic disorders like polyposis syndromes. These are patients are also at a higher risk. Such patients would have to talk to their primary doctor, gastroenterologist, colorectal surgeon, and get more frequent colonoscopy because they're at a higher risk.
All right. So hereditary plays into that as well?
Absolutely. Family history of colorectal cancer, whether if it's a first degree relative, it matters. What age did the first degree relative have the cancer?
Okay.
If unfortunately someone from our family develops cancer at a younger age, we should start screening process about 10 years prior to that. Because, like we said, the evolution of cancer, it starts from a bud. It's like a benign swelling, which is what we call as polyp. Polyps are not cancers. And those polyps go on to become larger polyps. Those larger polyps, if you don't remove them, they develop some precancerous changes.
All right.
And those precancerous changes, you don't touch them, they go on to become cancers. And those cancers spread to other parts of the body. We are taking advantage of this evolutionary process of cancer. It happens in most of the cancers. Close to 85-90% of the cancers go through these stages.
Okay.
So if we address that before or early stages, we can like literally nip it in the bud stage. Take out the polyp. Those polyps are not going to exist. Those polyps don't exist. They don't turn into cancers.
So you need to get a colonoscopy,
Absolutely.
right? And that's the way you determine whether a person has the polyps or not.
The magic number is 50.
All right, it's 50 years old.
Everybody over 50 years of age should get a colonoscopy, and everyone about 10 years after, every 10 years after, for average risk patients.
All right.
Unfortunately, African Americans have a higher risk of colorectal cancer, meaning they need to get their screening started at the age of 45.
If there are polyps that are found, is it still 10 years after that, or do the sequence of years get shorter?
Usually gets reduced to
Okay.
5 years and less than 5 years, depending on the type of the polyps, the size of the polyp, where it is found, whether you're able to remove it completely, and so on.
Okay. Well, can you walk somebody through what happens with a colonoscopy? Because I think people are like, no, I'm not going to do that. So let's
Yeah.
ease their fear about it a little bit.
You know, not the easiest thing to get a colonoscopy. The most important thing is not the colonoscopy. It's a bowel prep prior to that. And it takes about 24 hours. We give them clear, detailed instructions of what to do. There are a few bowel preps which are a little bit more friendly. Some are not that friendly, but does a better job. And so we will have to, unfortunately, put up with that. So I always tell others that if you come up with a bowel prep which is very friendly to the patient, you're a billionaire overnight.
Yes.
Because these bowel preps are not friendly. But I give them this analogy of the commercial which you see on the TV. A bank robbery goes on, and somebody stands down there and then says, "There's a bank robbery." And instead of addressing it, all the customers are looking, aren't you going to address it? No, I'm only a monitor. Similarly, I give that analogy because for breast cancer, you do mammogram, you only identify the cancer.
Right.
But in colonoscopy, you do the procedure, you identify a lesion, you take it out as well.
Okay.
So
Right
it's
then
like,
and there.
yeah, then and there. So, and then if it's all well, you get a 10-year lease.
All right.
And it only goes on between the ages of 50 and 75. Very interesting age for all of us, right?
Yeah,
Between 50 and
absolutely.
75. After 75 and 80, and it depends on how well is the person doing, what is his or risk factors are. And beyond 80, we don't really recommend screening unless there are clinical symptoms mandating a colonoscopy.
All right.
So the colonoscopy procedure is usually done as an outpatient. They get IV sedation. They can come and get it done, and they should have somebody to drive them home. It takes about half an hour, 45 minutes to do. Very straightforward procedure. Very rarely you can get into some complications related to that. Otherwise, pretty straightforward procedure.
All right. So don't wait. If you're at 50, be sure to go get that colonoscopy taken care of, because you may be saving your life. It depends on what you can't see and what you can't feel that may or may not be found.
Absolutely. Because of colonoscopy, there's been significant reduction in the rate of colon cancer mortality.
Yes, that's important.
So the silver lining, although we see a lot of cancers, the silver lining is over the last couple of decades, we've been seeing decreasing rate of death from colorectal cancer.
Yeah, that's great.
But still there is more room to improve, because our compliance rate, meaning anyone above 50, if he or she has had a colonoscopy, we are about 2/3.
All right.
Still there are about 1/3 in the community who haven't had a colonoscopy, and they're about 50.
Yeah, and that's a lot of people, obviously.
Yes, in this day and age, with the information available to our tips, during our social interaction with our friends and families, if you know someone who hasn't had one, probably start a dialogue with them and talk to them about it, the importance of it. Yeah.
Yes, and that's exactly why we're getting the information out to our viewers today.
Absolutely.
So
Kudos
all
to
right.
you.
Yeah, well, same to you. Thank you for that. So let's talk about if there is a cancer found. You need to treat it and move forward with that. So let's talk about that a little bit, treatment options.
So when you find, unfortunately, someone with a cancer, we look at the pathology and we do some tests and find out where exactly the cancer is. Is it just there? Has it spread anywhere else? So what we call a staging of cancer, that is very important, because the treatment depends on the staging of the cancer. If it's an early cancer, very early cancer, sometimes we can remove them during endoscopy. If this is a rectal cancer, we have facilities to remove by a procedure called transanal endoscopic microsurgery.
All right.
These are procedures with no scars, and use a microscope and remove those cancers, and could potentially even be done as an outpatient basis, a very short hospital stay, and they get it done, they remove, and that's it, potentially curative procedures. But if it is more advanced stage but locally limited, hasn't spread to other parts, then the options available are surgery, chemotherapy, and radiation in combination, or depending on where the cancer is. Early stage cancers, we can treat them curative intent, what we call as a surgery, curative surgery, and those who have advanced cancers would need chemotherapy or radiation therapy.
All right.
Very rarely we may have to give radiation therapy before, like in rectal cancers, before we operate on them. When we talk about surgery, that's when we need to talk about what types of surgery are available.
All right, so there's a different variety of different types of surgery, whether it's maybe invasive or not?
No, like very early stages we can remove by endoscopy or the microsurgery I'm talking about. But if it's advanced, we can do open operation. It's been like gold standard. For many years we've been doing that. And over the last 20-30 years, there's been more impetus and we are moving towards minimally invasive surgery. When I say minimally invasive surgery, we don't make big cuts on the anterior abdomen, on the belly wall. Instead, we make small cuts and use long instruments and do the operation. Like, in colloquial terms, people call laser surgery. There's no laser involved in, but what we call as laparoscopic surgery or robotic surgery. These robotic surgery has been out now for about last 10 years or so. There's been more increasing acceptance and prevalence of robotic surgery for colorectal cancer as well.
Okay, well, can you explain the robotic surgery and maybe how that differs from the open surgery, or just explain the options here?
A lot of issues related to operations are due to the access incision, how long it is, because the more the length of the incision, the pain, recovery of bowel function, how early you can get back to your normal life, how early you can get back to your work, pulmonary complications, meaning pneumonias, all those. There's a lot of things available, and plus, if you have a long incision, the risk of hernia is high, and so on. So what I say is, over the years, surgery has become more patient friendly.
Well, that's good to know.
Yeah, and what does it mean? Meaning, we do the same procedures, maybe get the same results or even better results by putting keyholes, usually 3 or 4 keyholes, and use long instruments like sticks. That is called laparoscopic surgery. What exactly happens? Those keyholes, long instrument, the surgeon stands by the bedside of the patient, by the side of the patient, and does the operation himself directly.
Okay.
And it has been shown by multiple studies that either equivalent or you get some better results because of all these post-operative outcome are better, less pain, early recovery, less complications, and so on. But when you use long instruments, like for instance, if you take your elbow, shoulder, elbow, and wrist, we have limitation with movements. And when you do these operations, we have limitation with getting to some critical areas. Even though we start these operations laparoscopically, sometimes we may have to convert it into an open operation. We call it conversion. It's definitely not a complication, it's just that it is part of the procedure sometimes. So I just want to keep that there. And now, what is robotic surgery? Robotic surgery is technically a misnomer.
All right.
It's not done by robots.
Well, let's explain it for viewers then.
Yeah, it is done by the surgeon.
All right.
He uses robotic arms. So it's exactly similar to laparoscopic surgery. You put keyholes in, you put those instruments in, you connect those instruments to the robotic arms. And now you go sit next to the patient on a console and you control those arms. What it does is you get precise movements. In areas which are a little difficult to reach, you can get to those areas. You get 3D vision and more accuracy. And the conversion to open operation is less. And the advantages we see with laparoscopic surgeries are little exaggerated, meaning more advantages with robotic surgery, meaning less pain. And anytime there's less pain, there's more gain.
Well, absolutely.
You get back, there are patients who get out of the hospital in 48 hours.
Yeah.
And that means they can get back to work soon. Not just the comfort of having less pain. In this day and age, when we have issues with opioid epidemics, there are some of my patients who have had even major operation, didn't have to take any narcotics post-operatively.
Yeah, that's great.
That's very nice for them, and it's very rewarding for us. I feel, when you see your patients not needing to take narcotics, you feel very happy about it.
Absolutely.
And also, unfortunately, if someone develops a cancer and needs chemotherapy or radiation therapy after open operation, we may have to wait for the wounds to heal. The wounds to heal with the laparoscopic operation or robotic operation are a lot less. So meaning they can get to the next stage of treatment quicker.
Yeah.
That means essentially we will let them live, we can control the disease better, more disease-free survival, more longevity.
Yeah.
So those are the advantages.
Yeah, that's great news. So we've covered a lot of topics on colon, rectal, the cancers, the surgeries, different things like that. I want to talk before the show ends about the pelvic floor and maybe some trouble, complications, and how that's dealt with.
Unfortunately, about 20 million of us in the country have issues with it.
20 million?
20 million.
That is an outstanding number.
Yeah. So it's more prevalent than we know of.
Yes,
and
because people don't talk about it, I bet.
Absolutely. And that's why these kind of programs will help. And unfortunately, it affects more elderly women, those who have had more kids.
Oh, okay.
Those who have had issues during childbirth.
All right.
And those are the patients. It's just not that incontinence. There are other issues related to pelvic floor as well, obstructive constipation and so on. And these are issues which patients are shy even to talk to their primary doctors. I just want the viewers to know these are issues can be addressed and their life can be more optimized and made better. And they can be evaluated by colorectal surgeons. We have some specific tests. Sometimes we need to do them. And a lot of time, they don't even need an operation. All they need is a little bit of lifestyle changes, and then the quality of life improves.
Absolutely. That's a terrible way to live without getting some help and assistance and being too embarrassed to talk about it. So just get over the hump and go get some help, huh?
Absolutely.
Yeah. So for all the people out there that are maybe suffering with some different things like that, do they start with their primary care physician? Is that where they should go first and then get referred if they need to?
They can talk to the primary physician and talk about it. The primary physician can make the appropriate referral to the colorectal surgeons. These days, patients have all the choice and they can always go to whoever they want. You know what I mean? It is in their hands, and they should be able to talk to their primary doctors and get the appropriate referrals.
Yeah, with that many people suffering from these types of things, I think it's important to get this information out there and let them know that you don't have to live with this, that there are, some options available here for you to feel better. We have a couple minutes left here. Are there any other advances, different things that you want to discuss before? Yeah,
even about robotic surgery, it's just not that robotic. We talked about colorectal surgery and robotic colorectal surgery mostly. Robotic surgery has a significant role in most surgical disciplines, okay? And the leading disciplines where robotic surgeries are practiced are general surgery, colorectal surgery, gynecological surgery, and urology, right? And I practice both general surgery and colorectal surgery. The general surgery procedures performed using robots are even gallbladders, and there are some advantages in doing them with a robot. And there are hernia operations, significantly better repairs are done and less painful and less recurrence rates. And all kinds of ball operations can be done with the robot as well. And and we also talked about the microsurgery, like scarless. There are certain tumors which can be removed using the microscope with no scars, and if you don't have a scar, there's no pain as well.
That's amazing, all the different advances, the digital technology, and being able to take a closer look with the monitor right there in front of you. That's got to be exciting for you too.
Yes, I put the analogy of a smartphone. We use the smartphone these days. It's improved so much.
Yeah.
You know what I mean?
Yeah.
So the most critical time of anyone's life is when he or she needs an operation. So that's when I think all of the technology should come and help him or her, and not when we are just having fun with our smartphones. I see that the developments which we see in our smartphones have been translated into the operating room similarly, and we've got all these advantages, technologies available to make it safer, easier, and comfortable for the patient so that we can do the procedure easier and make it safer for the patient as well.
All right, well, that sounds great. I'm glad to hear that you're making advances to help take care of the patient and give them back to normal daily life. It's been a pleasure talking to you today.
Thank you.
Thank you for your time.
Thank you as well.
And thank you for watching this episode of Being Well. If you need more information, check out our website at weiu.net. Click on Being Well. We'll see you next time.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HSHS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HSHS St. Anthony's Memorial Hospital.
Carle combines clinical care, health insurance, and research in a way that solves problems today with an eye toward the future. Supported by a deep philanthropic spirit and dedicated to making life better for as many as possible.